forma parte de la pandilla del Dr. Billy Mallon, urgenciólogo de LA County, profesor asistente, Keck School of Medicine de la Universidad de Southern California. Le damos la bienvenida al Dr. David Williams.
Check, check, check.
Perfect.
All right.
Oh, we need the...
I'm okay.
You're good. Okay.
Perfect. Buenas tardes, Santiago, Chile. ¡Woohoo! Primera cosa yo quiero decir, es mi primera visita aquí a Conferencia Conceptos y estoy muy alegre para estar aquí visitando colegas, amigos y tu país increíble. So, muchas gracias por invitarme. I will speak in English to spare the rest of you my Spanish, but I'm very excited to be here. I'm here to speak to you today about thoracostomy, tips and tricks. I have no conflicts of interest and I receive no funding, but I will be available following this lecture right out front for anyone who would like to create a conflict of interest for me. Here's our hospital, the new hospital here in the front, and the old stone mother back in the background. Well, let's talk about that first picture. This was an otherwise young, healthy male that presented to our emergency department with a chief complaint of shortness of breath. He was relatively asymptomatic. His vital signs were stable. He had no hypoxemia. And this is the chest x-ray that we got. So I think my first tip for chest tube thoracostomy is that sometimes we don't need a chest tube. And when I did some work down here in Santiago, I discovered that many of the residents were familiar with needle thoracostomy, but the needle thoracostomy tubes weren't being stocked in the emergency department. And specifically in these spontaneous pneumothoraces, where we have very little to no blood component, I think we should entertain needle thoracostomy and not chest tube. There's much less morbidity and mortality, trauma to your patient, much less pain. You may even avoid the procedural sedation that many people use in association with chest tubes. I'm done putting in chest tubes without procedural sedation. I just knock them out, and if the chest tube's indicated, then I put it in. But I've had great luck doing needle thoracostomy just with local anesthesia. You'll likely decrease your infectious complications, and you can offer your patient an anterior or a lateral placement. And if the lung re-expands, you can actually discharge the patient from the emergency department. So they're absolutely wonderful. This is the most common needle thoracostomy kit that's used, and it's a one-way flutter valve known as the Heimlich valve. It was created by Dr. Heimlich of the Heimlich maneuver, so you know it's good. You know it's good. Very easily placed. You use the syringe and an angiocath. It is introduced into the thorax. As soon as you get air, the angiocatheter is advanced all the way to the hub. And then it's connected via tubing to this one-way flutter valve. Then when the patient takes a breath, and there's that negative pressure of inspiration, the valve closes, air fills the lung, and then when the patient exhales, the positive pressure in the pleural space is allowed to exit through the one-way valve. So there's an inspiration, expiration, inspiration, expiration, and this is working extremely well. That's about all the movement you'll get out of a Heimlich valve. And you can see here, sterile prep, and our resident is doing an outstanding job. This is a laterally placed needle thoracostomy, and Dr. Johnson is very proud of her work. Post-procedural, you'll get a chest x-ray. And what I want you to really look at here is the needle thoracostomy connection here. Because you can see that the lung has re-expanded completely and has pushed the catheter up against the chest wall. In fact, right here at the second intercostal space, mid-clavicular line, it almost looks kinked. And I've seen providers think that a kinked Heimlich valve or needle thoracostomy is not functioning similarly to a kinked chest tube. This is not the case. This is functioning perfectly. It's functioning so well that the lung has completely re-expanded, and we're actually dealing with some re-expansion pulmonary edema in this patient. So this is a perfectly functioning Heimlich valve and doesn't need to be adjusted at all. So where else is needle thoracostomy being used? Well, primarily in the pre-hospital care setting. And let me say, our paramedics do an outstanding job auscultating decreased breath sounds on one side in patients in respiratory distress, maybe altered patients that have suffered significant trauma. But specifically when they become hypotensive is when clinical decompression, either unilaterally or bilaterally, is indicated, and they do an extremely good job. But even physicians have difficulty locating that second intercostal space in the midclavicular line. And all of our complications typically come from needles that are placed medial to the nipple. This is when the great vessels are struck. This is when the needles go into the heart, internal mammary artery transection. So frequently, lateral placement is now being encouraged. And it appears that in this patient, there shouldn't be any complications. The anatomy is good. But my patients look a little bit more similar to this. And the anatomy is much more challenging. So now as we observe the different interventions that go on, in about 20% of the patients, needles that are placed in the field may or may not actually even reach the thoracic cavity. So in this patient, had they even used the correct anatomic locations, the 5-centimeter length of needle thoracostomy would not even have reached the lung. And in fact, this patient didn't even have a pneumothorax. But I think when you try to listen through that much fat in the back of an ambulance with sirens going and you're bouncing around, it's quite challenging. And so what I want you to know is that when the patient shows up in your emergency department and has received needle thoracostomy in the field, if they still have tension physiology and they are hypotensive, you may need to place a second needle emergently while you prepare to do complete chest tube placement. But if their blood pressure has rebounded and they're more stable, you may be able to do a chest x-ray. Perhaps they didn't have a pneumothorax, perhaps the needle didn't get into the thoracic cavity, and they subsequently won't require a chest tube. So that's a second tip. So an optimally placed chest tube should go through the 4th or 5th intercostal space. It should go posterior to the lung and superior, right up to the apex. And in emergency medicine, we use the nipple to help us locate that 4th or 5th intercostal space. And you know when we're calculating medication doses and we use ideal body weight and then actual body weight? Well, we know that these nipples do like to migrate south sometimes as people age. So we are talking about ideal nipple location, where it should be. Okay, and this is important because I have seen morbidity and mortality induced if you go too low in these cases. So be sure to think about that. Most of the textbooks say you can use the anterior or mid-axillary line. And I'm going to actually argue that the majority of our morbidity and mortality from chest tube thoracostomy occurs when we have anterior placed chest tubes that induce pulmonary lacerations or mediastinal trauma. And actually, the mid-axillary line is the best place to go, and aiming posteriorly and superiorly. What size chest tube do we need? Well, we know the calculations for children. If we have an 8-year-old child, they would get a 6-0 endotracheal tube, and so their chest tube should be 24 French. Well, what do we grab for adults? 28, 36, 40? I never knew that children's blood was so much thinner than adults. And actually, this is the question that's being asked. We don't know what the right size chest tube is, but truly the morbidity and mortality of these large 36, 40 French chest tubes are truly being questioned. And we did a study in our hospital of comparing 36 French to 32 French and found no difference. And so we think going smaller may be less morbidity and mortality for the patient and less effective. I have yet to see a correctly placed chest tube clog from blood. So I typically choose 30 in adults. You can see here one of our residents. If you have time for a sterile prep and drape, that is wonderful. If you don't have time, we deal with emergencies where we don't have time. But this brings up the question of antibiotics. And antibiotics do show benefit in urgently placed chest tubes. So clearly in this emergent setting, whether it's the procedural risks of infection or perhaps from the penetrating trauma, antibiotics are indicated. We use a first or second generation cephalosporin, cefazolin, 1 or 2 grams IV. We leave the nipple exposed here. He has his finger on it for his landmark, and he makes a nice incision in that mid-axillary line. And make a generous incision, because you'll likely need room for your finger to make the initial entry into the chest, and perhaps even the chest tube as well if you're having difficulty. Now, this is the time to listen. If I have one clinical pearl for chest tube placement, this is it. Once you've made your incision and you take the hemostats, they should be pointed in that posterior and superior direction as you go through the ribs. If you're debating 2 rib levels, go to the higher one. Not all the way up in the axilla, but go to the higher one. Right above the neurovascular bundle, top of the rib, but aim them posteriorly and superiorly as you dissect the soft tissues. This is, I believe, the most important. I see residents, they think in the chest, out of the chest, and now I'll direct it with my finger. Very difficult. But if the soft tissues are already dissected in that posterior and superior direction, the tube typically goes in quite easily. So you can see here, as he puts in the hemostats, they're already pointed in that posterior and superior direction. And you want to give yourself kind of a generous blunt dissection, a generous opening here. So he puts in his finger, and you can use the hemostats to help introduce the tube, or perhaps you'll just put in the tube on its own. But getting it pointed in that posterior and superior direction, extremely useful. One of my colleagues, Dr. Paul Jeune, came up with this technique at our hospital: press and curl. So if you're having difficulty once you're putting the chest tube in, he recommends pressing it up against that thoracic wall. If you're dealing with adhesions, if you're dealing with blebs, making sure it's going in the correct direction. And you can even curl your finger around the tube as you begin to advance it. You don't want it going into the lung parenchyma, you want it going posteriorly and superiorly. This is a case we just had 2 weeks ago. Let the record reflect, I am supervising the chest tube going in on the left side. But both of these chest tubes, I think it's very important, are starting perfectly at the mid-axillary line. But I insist on the person I'm instructing that we dissect the soft tissues posteriorly and superiorly. So sure enough, as we start to go, do you see the direction of the two chest tubes? So this takes a real inferior direction. This goes anteriorly. So posterior direction, anterior direction. This one on this side ends up in the fourth intercostal space. Sorry. This ends up in the fourth intercostal space. This ends up in the fifth intercostal space. Okay, here we go. So you can see here, it's having a little trouble keeping up with us. And so what happens when we get into the chest? At this point, the hemothorax that this is being placed for is not being evacuated. So the patient will end up with a second chest tube, induces somewhat of a pulmonary laceration, and ends up in the mediastinum. And so we don't get to see all of the morbidity and mortality we induce by chest tubes. So we don't learn as readily. I started collecting cases when the surgeons would come down and complain, and I did find some legitimate critiques. And so that's why I started lecturing on this topic. An appropriately placed chest tube should go through that fourth or fifth intercostal space and up to the apex. There's a little gap in the radiolucent line that has to be in the thoracic cavity, because that's the last islet. You'll have an air leak if that is not within the thoracic cavity. So that's a nicely placed chest tube. Here, when someone goes through the eighth intercostal space, well, we can see the transhepatic approach to the perfectly placed chest tube, posterior and superior, didn't go over too well. And when you're dealing with obesity that pushed the organs up, when you're dealing with ruptured diaphragms, the 10th intercostal space is not okay. So these are the types of complications we do see. If the tube is not going easily, please don't force it. This is a chest tube that was placed and caused a pretty significant pulmonary laceration. 1 week later, after chest tube removal, pulmonary abscess formed. So again, these infectious and or traumatic complications can be severe. When it goes anterior and dissects into the mediastinum, you can see the chest tube here going anterior to the aorta, dissecting posteriorly to the mediastinum. And in our next case, this was a gentleman that was stabbed. He had a hemopneumothorax on the right, and the chest tube that we placed went in the right side of the chest, transected the mediastinum, and subsequently went into the right atrium of the heart. Do we have volume on this? Can you play audio? Or you can see here, so this gentleman just needed a chest tube thoracostomy and ended up with a midline sternotomy. So here they have their finger in the defect, in the hole, and as they film, you can see they're going to let their finger out of it. Here you go. There you go. So we are eternally indebted, and here's the sewn heart, clamped heart here, and they're pointing out where the chest tube dissected into the mediastinum and penetrated the right atrium. So unfortunately, as emergency medicine physicians, when we do this procedure frequently and don't get to see our complications, very skilled placement is necessary. So I hope I've shared some of my clinical pearls that I like to use. Consider needle thoracostomy, especially in spontaneous pneumothoraces. Consider the Heimlich valve. In the pre-hospital setting, the chest tube is not necessarily mandated. They'll frequently get one, but it may not be in the thoracic cavity. They may not have a pneumothorax. And if they still have tension physiology, you may need to cause a needle decompression. Sterile prep, drape, and antibiotics, when you have time, absolutely. What size chest tube? We don't know the right answer. And optimal placement. You want it to go posterior, superior up to the apex. Use the nipple as your landmark. I recommend the mid-axillary line. Dissect the soft tissues posteriorly and superiorly. Use push and curl if you find that useful to your technique. And don't force the tube. The complications are significant. Thank you very much.
Muchas gracias, doctor Williams, por